Okay, let's go ahead and get started. Kim, I'll hand it off to you.
Okay, thank you so much. I want to first just acknowledge the co-authors of this presentation. We formed a very wonderful collaborative work group through the Vestibular Disorders Association with Cynthia Ryan, who is my co-host for this webinar. She's the Executive Director of the Vestibular Disorders Association, as well as Jordan Tucker, who is a colleague, a physical therapist, and a vestibular specialist. So the three of us together are proud to present this presentation webinar for everyone, and we hope that it is really enlightening and informative for those of you who are tuning in. I want to just give you an overview. What we're going to cover in this webinar is an overview of falls in the older adult population, as well as a look at the balance system related to aging and pathology. We'll spend some time looking at how the vestibular dysfunction presents in older adults, and then we'll have a review of recommended best practices for preventing falls in geriatric patients, as well as just overall recommendations for best outcomes for this population. So right here, Cynthia has up on the screen some information for you about what I do. And essentially, I'm a doctor of physical therapy. I've been working as a PT since 2002 and exclusively in geriatrics since 2004, doing house calls. I've been evaluating the vestibular system of all my geriatric patients that are complaining of dizziness or vertigo or experiencing imbalance or unexplained repeated falls since about 2006. And I'm going to share with you what I've learned through my education, through continuing education, through my mentorship with researchers from around the country in vestibular rehabilitation, as well as my clinical experience. So thank you, Cynthia, for inviting me here today. And anyone that wants to stay in touch with me after this talk, I would love for you to sign up to join my mailing list or take some of my continuing education courses, which you can learn more about through my website there. Thank you, Cynthia. Let's roll into the poll questions here. So this is just to give us an idea of who's on the call with us today. We are interested in your response here, and I'll let Cynthia take over with these poll questions to get us started.
Okay, great. So I've just launched the first poll. This is the question, what proportion of your patients are seniors? Can everybody see that? Okay, good. Looks like people are starting to answer. I'm going to give everybody a little bit of time to answer that question so that we have an idea of what the demographics of our audience are today. We've got, so far, it looks like we have 74% of the respondents said, now 71% said that at more than 50% of their patients are seniors. 23% are saying less than 50%, and 3% are saying less than 25%. So we're going to, I just want to make sure those numbers aren't moving. Okay, great. I'm going to go ahead and close that poll. So the final results are 3% less than 25%. 23% of you said that less than 50% of your patients, but more than 25% are seniors, and 73% said that more than 50% of your patients are seniors. So quite a few of you. That I think that means that we have a topic that will be of interest to you. Kim, go ahead.
Okay, thank you, Cynthia. And I believe on the next slide we have a second poll question.
All right. What proportion of your patients have experienced a fall in the last year? Okay, I'm going to go ahead and launch that poll. Go ahead and take a few seconds to enter your responses. What proportion of your patients have experienced a fall in the past year, which is a good indication that this topic is also very timely, because the whole point of this is to prevent falls. Looks like we've got the numbers coming in, and I'm going to go ahead and close that poll. So the results are 30% said that less than 25% of their patients have fallen. 33% said that less than 50%, and 37% said more than 50%. Sounds about equal in all of those areas, but still quite a number of falls.
Okay, so we've got established here, we have an audience where the majority of our patients are are older adults, and the majority of our patients have had a fall in the last year. Is that what I got from that poll, Cynthia? Did I understand that correctly?
Yes, that sounds to be the case.
Okay, very good. So here we go. We're going to give you some content information that hopefully will begin to spark your interest for further learning, as well as give you some action steps that you can do starting immediately with these older adult patients. And really the idea is to help develop your understanding of what's going on here and what the best ways to get good outcomes are. And I want to make sure to be clear that today's June 25th, 2015, and this presentation represents a snapshot of what is a dynamic body of working knowledge that I'm working with. And so, you know, if we do a follow-up presentation next year, just to let you know that we may have other information we'll be presenting at that time. So this represents the truth as I understand it as of today, and I'm always learning with each new patient that I get. So we're going to talk about the prevalence of falls. Essentially, this 1/3 of adults over 65 fall each year, but only about half of them are talking to their doctor about it. And the really interesting thing for me with this statistic is that the current estimate is that about 35% of Americans over 40 years old have a vestibular dysfunction, whether it's you know, causing clinical symptoms or not. And so in my practice and in my mind, that's a very similar population. In my perspective, those are the same people. The people over 40 that have a vestibular problem, and the people over 65 that are having unexplained repeated falls. That's what I'm seeing out here. Of those who fall, a really big deal is that about 50 to 75% of them are going to fall again within 6 months. So the falls really need to be a wake-up call to have a further intervention. In fact, one of the resources we'll be sharing with you through this webinar is a new data brief on deaths from unintentional injury among adults aged 65 and over in the United States between 2000 and 2013. This report just came out in May of 2015, and it's stating that between 2000 and 2013, the age-adjusted fall injury death rate among adults aged 65 and over has nearly doubled, from 29.6 per 100,000 to 56.7 per 100,000. So we're looking at an increase in that fall injury death rate, as well as an increase in the volume, the population that's over 65. So this is really an urgent message that we're bringing to you today. Thank you, Cynthia. Next slide, please. So the financial cost of falls, we're looking at a huge cost, and we all know this because we all see these people that are having fractures, needing surgeries, getting traumatic brain injuries, unable to return home and live alone again, costing a lot of money and suffering a lot. Of those who are falling, about 20 to 30% will incur these serious injuries, such as hip fractures, traumatic brain injuries, that will prevent them from returning home and living alone again. So we really want to look at preventing the falls in order to improve the quality of life of our aging population and those that we love and care about. In terms of the psychosocial cost of falls, we all see this going on with our patients. As soon as they start to fall, they begin having falls, then they begin to develop the fear of falling, which is the most common fear reported in the elderly. That also then leads to social anxiety, where they don't want to leave their home. Sometimes they can even develop agoraphobic behavioral tendencies, and eventually it can lead to depression, suicidal ideation, as well as increasing the caregiver burden and reducing their quality of life. So if we can get on top of the falls, then essentially the ripple effect for our whole community is really there for us. In terms of, you know, how people are falling and when people are falling, in older adults age 65 and over, this comes from the San Diego County public health report, that this is really shown in many different public health reports that I've reviewed, which is that the most common place that older adults are falling is in their own home. They're slipping and tripping on level surfaces. Now, we do occasionally have the people who have a limited awareness of their balance limitations. They don't have awareness of their balance limitations, and so they're doing risk-taking behaviors like climbing ladders, stepping on step stools, and we do have a small percentage of people that are falling from those risky behaviors, but the overall majority of people are falling by slipping and tripping on level surfaces. So here comes our third question, our poll question. I'll take it turn it over to Cynthia here to address this question for us.
Okay, so our third question is, how comfortable are you assessing the vestibular system in geriatric patients who are complaining of dizziness or vertigo? This is, I'm going to go ahead and launch this so you can start answering it. This is just to give us an idea of the level of experience of some of our attendees, so that Kim can have an idea of you know, how to present the information that's in this presentation. The presentation is geared to be actually quite comprehensive, but this will give us an idea of how quickly we can go through some of the areas. So looks like our numbers are coming in, and I'm going to close the poll. About 19% said that they're not at all comfortable in assessing their geriatric patients. 31% said they're somewhat comfortable, and 50% said very comfortable. So I'm glad to see that there are quite a number of you out there who have experience with geriatric patients. Hopefully we have something to share with you as well. But it looks like about 50% of our audience is not very comfortable assessing their geriatric patients. Kim.
Okay, got it. Very good. And that's exactly what I sort of hear from my colleagues as well, is that, and I felt the same way before I started studying this as a focus of my career, you know, just kind of looking at people that are having unexplained repeated falls or that are complaining of dizziness and vertigo, and just sort of where do you start with that? And so we're going to take a look at right now how balance works, an overview of the balance system. Then we're going to take a look at the different subcomponents of balance and how they are affected by aging, normal aging, as well as pathology or disease. And I just want to be clear that this is part of a curriculum that I teach, that's 24-hour course that I call it's the Bell method of how to assess these older adults with these complaints. And so this is a very brief overview, but hope maybe for those of you who have experience, it gives you one or two more things you can start to consider when you're assessing your patients. And for those of you who are just beginning, maybe it starts to entice you to want to learn and study some more about this. So as far as the balance system, essentially our balance system is always running in the background, and it has afferent input, which is coming from the sensory part of our nervous system to our brain, and then it has efferent output, which is essentially the motor aspect, which is what our brain is effecting as a response to the sensory information that we're getting. And the brain is processing all that information all the time, which is creating our upright posture, our equilibrium, our ability to move through space with balance, and our ability to stabilize our gaze, meaning for our visual field to remain stable as our head is moving around and we're looking at visual targets. So let's look at the next slide there, Cynthia. That has a nice overview. So here we have a nice overview of how balance works. This is actually part of what we created with the San Diego County Fall Prevention Task Force. We teach this out in the community for people to understand the basics. Here we have the three afferent sensory inputs that I was mentioning, the vision, then somatosensory, which is essentially like from the muscles, the muscle spindles, the joint proprioceptors, the cutaneous and pressure receptors in the skin and the fascia. And so that's going to be, the somatosensory is our musculoskeletal system, and then the vestibular is going to be coming from our inner ear. The brain processes all that information and compares it to each other and to the right and left side, between the right and left sides of the body, as well as from one system to the other, and then it creates the three-dimensional picture of where we are in space, which gives us our postural control, our alignment, our muscle tone, our ability to coordinate and react with our balance. So when we look at the causes of falls in older adults, one of the things that I want to be clear on is that falls are usually multifactorial, as well as dizziness. So it's not like we're going to just pick up one reason why someone is falling or complaining of dizziness and think that that represents the whole picture. We really want to be looking at all the different possible causes, because the more fall risk factors that we identify and address, it actually has an exponential effect on reducing fall risk. That's been shown by Mary Tinetti in some research that she's published. So in general, we want to be considering that a lot of older adults are going to be having reduced strength and flexibility, changes to their vision and the sensation in their feet, which is that somatosensory input. They're going to have some vestibular degeneration. It's been shown that older adults have slower balance reactions, meaning when they have a displacement of their center of mass outside of their base of support, or they have a loss of balance or a loss of equilibrium, the latency of onset for their muscles to fire in response to that is delayed and it's increased, meaning that by the time their muscles actually affect the balance response, a lot of times they're on the ground. And that's a universal change with aging, but it can be improved with balance training. And we also have a lot of older adults that are having side effects from their medications, drug interactions, interactions with alcohol, and then chronic health conditions that are not being well managed, like blood pressure issues, diabetes, visual diseases, and then some home safety issues. So these are all the things that really need to be looked at when we're doing a multifactorial approach for older adults that are falling. In terms of the loss of strength and flexibility, we know that reduction in hip extension strength and range of motion is one of the things we want to be looking at with our older adults. It's a pretty common musculoskeletal change with aging. And so just doing like sit-to-stand exercises are really good for strengthening the glutes and the hip extensors, as well as tibialis anterior weakness, which is the muscle that lifts the toes up as we're taking a step and prevents our toes from dragging on the ground. Weakness in that muscle is also associated with fall risk. So we want to be looking for that and doing some strengthening to the ankles if we can. We're seeing the loss of strength and flexibility with people because they are moving into a sedentary lifestyle and retirement, as well as suffering from things like illness, depression, and surgery that are causing them to have bed rest and periods of immobility, and then they're just not getting back on their feet again. So that is the strength and flexibility piece. Now, in terms of decreased vision, there's really two things we want to be thinking of with the balance systems, the visual system, the somatosensory system, and the vestibular system. And that is, we want to be thinking about normal aging, what's normal across the board, and then what's pathological, and what that means anyways. And so in terms of decreased vision, one of the things to know is that there are normal changes to the visual system with aging. We'll be going over that one of the next slides. And then we have more than 2/3 of people in this country that have been diagnosed with low vision or visual disease and pathology are 65 and older. So we have a high number of older adults that are also suffering with visual diseases in addition to normal aging of the eye. And those visual eye diseases are going to be your glaucoma, your macular degeneration, your diabetic retinopathy, and your cataracts. Now, first eye cataract surgery has been shown to reduce fall risk and is recommended as an intervention to reduce fall risk. In terms of glaucoma, macular degeneration, and diabetic retinopathy, the recommendation there is to work with your doctor, or for the patient to work with their doctor to manage that medical condition. So really what happens is we have those three inputs that come to our brain to create our balance: our visual system, our somatosensory system, and our vestibular system. And what happens is a lot of times people are relying on their vision for balance. The visual system tells us where we are in relation to our surrounding environment. So especially for patients with visual impairment, home safety recommendations and clearing the clutter from the walkways is going to be very important. The way we can distinguish between visual complaints that are from the vestibular system and visual complaints that are from eye disease, pathology, or the central nervous system is essentially that the visual complaints that are going to occur at rest while the person is stationary are usually going to be related to eye disease, pathology, or central nervous system issues. And then the visual complaints, like a blurring of the visual field or a wavy pattern in the visual field that occur with head motion, are usually going to be related to a problem with the peripheral vestibular system because it's not stabilizing the gaze while the head is moving. So in terms of differential diagnosis, that's a key point to distinguish. And that will determine how you refer from there, because if someone has a visual complaint where they're sitting at rest, then they need to see an ophthalmologist or a neurologist. But if they have a visual complaint while their head is in motion, then maybe they need vestibular rehab, and that's the extent of intervention that they need. So that's important to differentiate visual complaints. And then we have the normal aging of the visual system. where this is going to be across the board an issue. We're going to have, our older adults are going to have a difficulty with their depth perception, with color discrimination, with contrast sensitivity, and we see this when we look at driving and determining the difference between red lights and green lights. It's difficult to do with the aging eye, and they're also going to have an increased sensitivity to glare, as well as needing more light to see what they used to be able to see with less light. So they're usually going to need to increase the lighting in their home, put some kind of window covers or screen covers in place to reduce glare, and then just to be more aware of, taking their time when they're negotiating curbs or steps, because they may not be able to clearly see where the edge is because of that reduction in contrast sensitivity. Also, the other thing in terms of visual changes that is really important to prevent falls is the pupillary dilation time is slower. So when older adults are outdoors, I'm sorry, the pupillary constriction and dilation time. So when older adults are outdoors and their pupil is constricted because of the bright sunlight, and then they come inside and it's the middle of the afternoon and it's slightly darker in the indoors, then their pupil just takes longer to dilate than it used to when they were younger. And so they may actually experience a period of transient blindness when they come in from outside during bright days. And so I usually advise people to either sit down or stand against the wall until their eyes adjust to a change in lighting coming into a darker room from a bright light outside. Now we're going to look at decreased. So I'm sorry, that recommendation, that last recommendation, is a universal recommendation for the aging eye that is separate from recommendations for visual pathology, which usually have to do with medical management. Now, in terms of the somatosensory system, we have a decrease in proprioception a lot of times that our older adults are dealing with, and the changes to the somatosensory system in terms of normal aging we'll have a look at here, as well as peripheral neuropathy. So in terms of normal aging of the somatosensory system, we're going to have a loss of skeletal muscle mass. We're going to have an increase in our slow twitch muscle fibers and a relative reduction in our fast twitch muscle fibers, which slows the speed of muscle contraction and slows the lower extremity reaction time. That's also going to be shown in our slower balance reactions. So a lot of times they also show weakness in the hip and thigh, the proximal muscle strength with aging. So that's going to be considered fairly normal in terms of aging, but we can still address it in our treatment plans by working on strengthening. Now in terms of peripheral neuropathy, so for all patients, we want to be looking at the strength of their hips and thigh muscles and having them doing strengthening exercises to strengthen their core muscles and their glute muscles if they're showing weakness that's closely related to normal aging. And then we also want to be on the lookout for peripheral neuropathy. And I'll tell you, I have worked very closely with a podiatrist here in San Diego County who has taught me a lot about the fact that there's so many people out there that have idiopathic peripheral neuropathy. And now that I've started testing sensation, checking peripheral pulses, and looking for signs of peripheral vascular disease on all my patients who are having imbalance or chronic repeated falls, I can't tell you how many people I discover that have undiagnosed peripheral neuropathy, essentially, that I might be the first person to be reporting it back to their physician that I'm identifying this. And what a relief it is when we figure that out and we can do some interventions to address their sensation and their strength in their feet and ankles. So people that have peripheral neuropathy, you're going to see them functionally. What's going to be happening is they're going to usually have trouble on unstable surfaces, like they might have a loss of balance on a piece of foam or on grass or sand, things like that, or while transitioning from carpet to tile, say, for example. We're going to find peripheral neuropathy, as I mentioned, in just community-dwelling older adults who have no diagnosis that would cause us to think they might have it. We're just going to be finding it as we start looking for it in people. And then we also are going to be finding this peripheral neuropathy in people with diabetes, people with diagnosed peripheral vascular disease, it's commonly it can be a common side effect of chemotherapy. We might see this in our cancer survivors, and then people that have just general issues with blood flow and circulation. Of course, I just want to be clear also, peripheral neuropathy shows up in some neurological disorders as well, like different neurological diseases and disorders of the central nervous system can also have peripheral neuropathy, like maybe a MS or spinal stenosis. Things like that can show peripheral neuropathy as well, that we might be identifying patients with those diagnoses that have peripheral neuropathy, and that can be a cause of their imbalance. So now we've taken a look at the visual system. We've taken a look at the somatosensory system, both normal aging as well as pathology. We've done a little brief discussion on how to manage those things. And now we're going to take a look at the third balance system, which is really the focus of this presentation, which is the vestibular system. So what we have here on the screen is a really nice diagram of the inner ear. And I just want to invite everyone who's listening to just take your index finger and place it essentially on your cheekbone, where your cheekbone kind of meets your ear right there. And that is the bone in which your vestibular system is housed entirely. It lives inside there. So that's the hard structure that encases and encapsulates our vestibular system. And that, it's sort of like a gyroscope inside our head that responds to the forces of gravity in this gravito-inertial field in which we're moving. And it tells us where we are in relation to the pull of gravity when we're just standing still, as well as when we're moving. So the vestibular system has 5 end organs in each ear. It has 2 otolithic organs and 3 semicircular canals in the right ear, as well as in the left ear. And those end organs have sensory hair cells in them that transmit electrical impulses through the vestibular nerve into the brain to the vestibular nuclei, which then communicate with the other side, as well as process information through the cortex and the cerebellum and down the spinal cord to the muscles of the of the spine, as well as the extraocular muscles that stabilize the gaze. So the vestibular system is subject to normal aging, just like everything else in the body. And what we see is that essentially the whole system is aging. The peripheral sensory end organs are aging by having a degeneration in the membranes where the otoconia, or the crystals that cause BPPV, where they're supposed to be, the utricular macula, that membrane degenerates, which is part of the reason why we are seeing a higher prevalence of BPPV in older adults, as well as a reduction in the total number of otoconia in the inner ear, some reduction in the hair cells, a reduced a loss of nerve fibers communicating from the ear to the brain, and then a degeneration of the central vestibular system in the brainstem. So essentially the whole system is subject to aging, but because of the brain's ability to adapt and compensate to a reduction in afferent input from the vestibular system that's occurring gradually and mildly with normal aging, the normal aging process of the vestibular system has been basically proposed to be a model for vestibular compensation. So essentially, the theory is that if the person's brain is compensating to normal aging appropriately, that they won't show any deficits from the gradual mild vestibular loss that they're experiencing. So in terms of the way vestibular dysfunction shows up across the lifespan, we do see vestibular dysfunction across the lifespan. As I mentioned, about 35% of people over 40 years old in the United States have vestibular dysfunction, whether it's showing up clinically and causing symptoms or not. But the prevalence of vestibular dysfunction does significantly increase with age. It peaks in the 6th and 7th decade of life, which is in the 50s and 60s. And it's higher in people with cardiovascular risk factors like smoking, heavy tobacco use, high blood pressure, and it's higher in people with diabetes. In fact, there's about a 70% prevalence of vestibular issues in people with diabetes. My theory on that is the microvascular ischemic changes in the vestibular system, but You know, a lot of this is theoretical, so I haven't seen a specific reason why, but it is associated with cardiovascular risk factors. So in terms of identifying people with vestibular disorders, this is where I really want to get this urgent message to you to really start to help identify people that are walking around with undiagnosed vestibular disorders, because it is a miserable experience to have an undiagnosed vestibular disorder, and especially going from doctor to doctor and provider to provider. And if you are on this call right now and you can help identify one of your patients that has some of these symptoms and help them figure out that they have a vestibular disorder and get it assessed appropriately and treated, you have the potential to change someone's life completely and prevent them from experiencing severe anxiety, depression, and potential suicidal ideation from chronic unexplained symptoms. So in terms of the symptoms of vestibular disorders, what we're seeing here are unexplained repeated falls, even in people that are not complaining of vertigo or dizziness. People that are complaining of imbalance and unsteadiness a lot of times may have a vestibular problem. If they're having problems with walking or ataxic gait, if they lose their balance while they turn their head when they're walking. I also see this when people are driving. If they're driving and they turn their head while they're driving and they tend to veer the car off the road or veer out of their lane, a lot of times it's because they have a vestibular problem. Then we do also have people that are actively complaining of dizziness that are having about 45 to 50% of them have a vestibular problem. Sometimes people will say they're having vertigo that's triggered by changes in head position. That can be from BPPV. It can also be from other vestibular issues. A lot of times vestibular problems will co-occur with problems with concentration, memory, what's called cognitive stamina, which is sort of concentration over a long period of time. People with vestibular problems often complain of mental fogginess and fear of falling. And then they have that those visual complaints, as I mentioned earlier, that occur with head motion. So that's going to be, you know, when I turn my head quickly, it looks like my visual field jumps around, or it looks like I get wavy patterns in my blinds or something like that. Those are going to be complaints of people with vestibular problems. We call that oscillopsia, and that's the illusion of movement of objects that are known to be stationary.
And Kim, I just wanted to, this is Cynthia, I just wanted
So
to
as I mentioned, yes.
Interject here and kind of repeat what you said about the importance of helping these people get diagnosed. Because what we hear all the time is that patients, especially older patients, are told that this is just a normal part of aging, that there's nothing that they can do about it. And we know that that's not true, that that balance disorders are not necessarily a normal part of aging, that there is something they can do about it, even if it is just a normal part of their aging. And we really, we know that once a vestibular patient gets to a physician who can accurately diagnose them, that then they get the help that they need, and they lead a much more fulfilling life. So I just wanted to kind of re-emphasize that identifying vestibular patients and helping them get a diagnosis really not only gets them on the road to recovery, but gives them a lot of peace of mind to know that they're not going crazy and that there is a cause, a reason that this is happening to them. Back to you, Kim.
Yes, thank you so much. Absolutely. In fact, I know your organization just put out a really nice article recently about what you call the anxiety of waiting for a diagnosis. And so it is true that not only are they suffering from the disturbance to their nervous system from the vertigo or the fear of falling and whatever else they have going on, but then they also have the mental health overlay of just being very anxious and feeling like nobody understands them. People are telling them it's all in their head. They look like they're fine. You know, there's this whole psychology that goes with having a vestibular issue that we can really help kind of rescue these people if we're really sharp with assessing for symptoms of vestibular problems. Even in people that have seen many, many doctors. I had a young man recently come to me who had seen 53 physicians over 7 years. and had not gotten adequate diagnosis yet. And then I have a patient now from another country who's been traveling to different countries around the world looking for a diagnosis. So, you know, if we can help these people, we're relieving their suffering really a lot, and you'd be surprised what you can find even in people that have seen other doctors and healthcare providers. So in terms of looking at, we just looked at common presentations of people with vestibular disorders, and I emphasize that because there's so many people I see with undiagnosed vestibular problems. But I just want to be clear also, this is a really important point, that people can have a vestibular disorder and be complaining of dizziness and vertigo as sort of that's one population, the people that have complaints of dizziness and vertigo and have vestibular disorders. The vestibular system is responsible for about 45 to 50% of, or it's a factor in patients, about 45 to 50% of people that are complaining actively of dizziness and vertigo. Because keep in mind, there's other things that cause dizziness and vertigo. But then you also have your population of people that are not complaining of dizziness and vertigo, but they still have an undiagnosed vestibular disorder, and those are your people with chronic unexplained repeated falls from what I've seen. So this slide is really important to show that people with a vestibular disorder and complaints of dizziness have 12 times more likely risk of falling. But the people that have an undiagnosed vestibular disorder and have no complaint of dizziness, zero complaint of dizziness, they still are 6 times more likely to fall. And so that's why it's really important that we are assessing the vestibular system in these older adults that are having chronic unexplained repeated falls, even in the absence of complaints of dizziness and vertigo. So in terms of dizziness, just a few more details. Dizziness is the most common complaint to physicians from patients over 70. So for those of you on this call that have the majority of your patients are over 65, really important for you to continue to study and practice to really try to master the differential diagnosis of dizziness for those folks. As I mentioned, about 45 to 50% of the time there's a vestibular component, but dizziness is usually multifactorial. So we want to make sure we're partnering with the physicians involved in the medical management for these patients, because a lot of times we need some intervention regarding medications, medication side effects, drug interactions, maybe a cardiac assessment, especially if they're having dizziness and vertigo that's coming on intermittently at rest. They might be having cardiac arrhythmia, and then we may need some other medical intervention for things like diabetes, endocrine disorders, or blood pressure issues. So really important to involve the physician, the referring physician or the primary care physician in these assessments as well. So other causes of dizziness besides the vestibular system that we want to be considering and making sure that we are ruling out essentially in our people complaining of dizziness is, of course, the vestibular disorders. That's part of our assessment. Other things that can cause dizziness are going to be disorders of the central nervous system, like Parkinson's, MS, history of stroke, things like that. Migraines or sinus headaches can cause dizziness. We have the vestibular migraines that can cause vertigo. Blood pressure issues, medication side effects, drug interactions, use of alcohol, blood sugar fluctuations in people, especially people with diabetes, that are going to get hypoglycemic or hyperglycemic. We have the dehydration contributing to dizziness. Now that's going to be especially amplified in our older adults because for 2 reasons I've seen. Number one, because older people tend to have a reduced sensation of thirst, so they're just not as likely to drink as younger people, as well as they have a lot of problems with their bladder leaking sometimes. Women that have had children and men that have any prostate involvement I've experienced will have bladder accidents or get up multiple times at night to go to the bathroom, so they may be purposefully dehydrating themselves in order to avoid accidents. And then in people with Meniere's issues, that can cause a Meniere's episode. And in general, for general population, it can just cause dizziness. So that's why, as part of my approach when I work with older people, I do address bladder retraining so that they can hydrate themselves appropriately and not get dizzy from dehydration. Other things that cause dizziness would be nutritional issues, electrolyte issues, especially in patients with medications that cause electrolyte imbalances. Sometimes certain medications require electrolyte monitoring. As I mentioned, the irregular heart rhythm or the cardiac arrhythmia can cause dizziness at rest. It's intermittent. Low oxygen levels can cause dizziness with exertion or dyspnea on exertion. And then we have anxiety contributing to dizziness with hyperventilation episodes. And sometimes neck tension, just general tension in the neck, can contribute to dizziness from trigger points in the muscles around the neck. They can cause radiating pain to the side of the head or symptoms of dizziness as a manifestation of those trigger points in the neck. And then just general stress can cause dizziness as well. A lot of times that has to do with the hyperventilation or the anxiety piece. So in terms of looking at what the most common vestibular disorders are that are diagnosed in older adults, BPPV, that is the benign paroxysmal positional vertigo, is the most common vestibular disorder, and this is what occurs when those crystals that are normally supposed to be on that utricular macula, which degenerates with aging, when those crystals get loose and they go into a semicircular canal where they're not supposed to be. It's really a biomechanical problem. It's not a disease or pathology, and it doesn't cause a consistent, continuous complaint of vertigo. It's only causing vertigo complaints in certain positions, but it is causing a consistent underlying problem with balance and gait and walking. So about 30 to 40% of people with BPPV have a spontaneous resolution. The other 60 to 70% have it for the rest of their life, and we're going to talk about this in more detail because this is a big deal and probably one of the places where our audience can make the biggest difference for their patients. In terms of Meniere's disease, this is also a common vestibular diagnosis that we see in older adults. But I just want to say that in my experience, I've had probably at least half of the patients I've seen that come to me with a diagnosis of Meniere's disease that's given to them by a physician who's not a specialist in the vestibular system, such as a primary care doctor or a geriatric doctor of some sort. A lot of times I see people with more of what I would consider to be a Meniere's migraine variant, meaning their symptoms are not classic Meniere's disease or Meniere's syndrome. It's more of a migraine presentation. And so we want to, I think it's really important for anyone who has been diagnosed with Meniere's disease by someone who's not a vestibular specialist to make their way to a vestibular specialist to manage that in the long term, just to make sure they're on the right medications and they have the right dietary and lifestyle recommendations to reduce the episodic nature of vertigo with either the migraines or the Meniere's. And then the vestibular neuritis, of course, people can get that at any age. Typically what I see in older adults is not so much of a new onset of vestibular neuritis or labyrinthitis, which would be the infection, the viral or bacterial infection of either the vestibular nerve or the labyrinth itself, the end organ itself. I don't see so often those new cases in older adults, but what I see are the vestibular decompensation of old cases of the vestibular neuritis and labyrinthitis. So we'll take a closer look at that. So in terms of BPPV, now we're going to talk about this a little bit more detail. BPPV is that where those calcium carbonate crystals or the otoconia get loose in the inner ear. As I mentioned, it's a biomechanical problem. The peak incidence for this are people in their 50s and 60s, and the report just came out actually within the last quarter. There was a publication stating that there's a 6.8 to 1 ratio of women to men that are getting this condition in their 50s and 60s. And so in my private practice in San Diego County, which I only accept cash, I don't have an insurance-based practice model, so my target customer for my private practice are essentially women in their 50s that are experiencing BPPV as they're going through menopause. So it's a huge population for this issue, and then what I'm seeing happening is the women that don't get it treated and don't have the luck of spontaneous resolution, then they're having BPPV essentially through the end of their lifespan unless they start falling and then they get assessed by a vestibular specialist who identifies it and clears it up for them. So here's just a little bit of a closer look at the vestibular, sort of the end organ there. And what you can see is the utricle. On this slide, you can see the utricle, which is one of the otolithic organs that houses the otoconia and senses linear acceleration and deceleration through space, as well as static tilt of the head. That utricle has the otoconia in it normally on the macula, which is the sort of the sensory apparatus inside there. And either through head trauma or just through normal aging, the otoconia there are sort of sloughing off, coming out of the utricle, and you can see they're ending up at the bottom right corner. It says close-up of otoconia displaced from the utricle. So they're ending up in the posterior canal, which is where they're not supposed to be. And we find that type of BPPV in about 90% of, I think it's like 85 to 90% of BPPV cases are in the posterior canal. So the average person with BPPV sees between 4 and 5 different doctors and spends an average of $2,000 before they actually arrive at a diagnosis. And so a lot of older adults, especially who aren't able to advocate for themselves or just sort of take the first word of the first doctor that they meet with and don't continue to pursue further assessment, either they're going to just keep suffering for a long time, or they're going to be on long-term vestibular suppressant medication. Typically meclizine is the one that we see commonly prescribed. And then they may even undergo unnecessary diagnostic testing and things like that to, you know, like for example, if someone has a BPPV, then they get an MRI of their brain. That's not going to show anything to indicate they have BPPV. So a lot of times people are undergoing unnecessary diagnostic testing, where if they were just to get to a vestibular specialist right away and get the BPPV treated, then they wouldn't have to stay on this medication long term or get diagnostic testing done that's going to cost them a lot of money and just take up their time and expose them to radiation or any other things like that. I had one young man recently who had spent over $30,000 on diagnostic testing and consultations for his vertigo. So I think that that estimate of $2,000 is like we said, that's average. So in terms of the prognosis for BPPV, essentially the American Academy of Otolaryngologists has put out a clinical practice guideline for BPPV, which is one of the resources we have available for you to access as part of this webinar. And in there, it's actually on page S59 of that clinical practice guideline. It is recommended that older adults with chronic falls, especially people over 65, are screened for BPPV because of its prevalence in older adults and its contribution to falls. So that's really recommended for all older adults to be screened for BPPV, especially for those who are having chronic unexplained repeated falls. And in fact, I just got an article from one of the members of my vestibular study group last week, which I shared with Cynthia, and she's going to make a reference to it available for the audience as well. And that article was talking about how in Taiwan, they did a study, they just published a study showing that people with BPPV actually have an increased risk of fracture as well when they fall. So it's not just falls, it's also the fractures that are more common in people with undiagnosed BPPV. The most common treatment for BPPV is called the Epley maneuver, where we just reposition those crystals, kind of like a pinball game, essentially, with the skull, using the force of gravity, and it can fix BPPV in one treatment about 90% of the time, 85 to 90% of the time. And so it's really great. It's a great day to be a healthcare provider when we find someone that we can fix this easily. But I will mention that that treatment, the Epley maneuver, was developed in 1992 by John Epley. So in my experience, healthcare providers that graduated from school before that may not be too familiar with this intervention. And then, so we want to really identify when people graduated from their medical school or their, physical therapy school, and then if they haven't accessed this information as continuing education, then they may not be familiar with vestibular rehabilitation and these type of maneuvers to fix vertigo.
Kim, I'm just going to interject and clarify. You had mentioned that we have some handouts. So I want to direct everyone's attention to that. You can take a look in your GoToMeeting menu bar. There should be a little area underneath questions that says handouts. There are 5 handouts that you can download from there. We'll also include an email that will be sent to you tomorrow after the webinar that has links to some other resources that Kim is referring to. So, and if you have any problems accessing that information, please feel free to contact us. Back to you, Kim.
Okay, great. Thank you. I think we're ready for the next slide. Okay. So now we're just going to kind of run through, we've talked about the overview of falls. We've looked at the balance system. We've looked at the visual, the somatosensory, and the vestibular system, normal aging, as well as pathology. And now we're going to just talk about some common presentations of vestibular issues in older adults. Then we're going to move on to geriatric fall prevention, best practices, and overall recommendations. So we're on the home stretch here as far as the content goes. So for vestibular decompensation, what this is really, this is important for us to understand. This is not going to come across as an ICD-9 code. This is not a diagnosable presentation that you're going to get. But what you want to be alert for is when this is happening so that you can identify when a previously subclinical vestibular dysfunction is now manifesting as a new vestibular problem or a new complaint of dizziness, vertigo, imbalance, or unexplained repeated falls in the absence of dizziness and vertigo. And so that's going to be coming with people that are experiencing vestibular decompensation. Now, in younger people, that 35% of people over 40 that have a vestibular problem, those people have, you know, they're not going to be necessarily complaining of vestibular symptoms because their brain is compensating, or their brain is compensating for that erroneous vestibular input that they have from their vestibular dysfunction. And so what can happen is, as long as the person stays active, that it's required for them to have a lifetime of active head motion to keep their vestibular dysfunction integrated and compensated for by their brain. And it requires head motion and visual input. So what happens in older adults, if they experience a period of relative immobility, such as a hospitalization, an illness, a surgery, a period of bed rest, if their spouse dies, if they're grieving, if they get depressed, and they're not moving their head as much, then their vestibular system can decompensate, meaning the brain stops working so hard to process the mismatched vestibular information that's coming in from the right and left ears from the damage that they have that's not been causing them a problem before, and now it's causing them a problem at this point because their brain has essentially decompensated. So those people do really well with a referral to vestibular rehabilitation. And that's a key thing to look for if people are complaining of new onset of balance problems or new onset of falls or a new onset of dizziness or vertigo after a period of immobility. They may have had a previously subclinical vestibular dysfunction that's now showing up as a new problem. And then we have the group of people that we've been sort of massaging this group of people for a while, trying to figure out how to call what they're experiencing. We've had chronic subjective vertigo, we've had space and motion discomfort, and now we've sort of arrived at a new term which we call 3PD, which is persistent postural perceptual dizziness. And these are going to be the people that are complaining of visual triggers for vertigo in, like, for example, when I stand at, you know, looking over a balcony, I feel like I have vertigo. Or when I'm walking through Walmart or Costco, I feel like I have vertigo. When I'm in a crowd, I'm getting symptoms of vertigo. And maybe those symptoms are beyond what we would have expected based on the extent of their vestibular dysfunction upon our exam. And so these people usually benefit from co-occurring mental health, professional mental health support as well to address any social anxiety or agoraphobic tendencies that might come along with this. And then they respond really well to vestibular rehab, but it just takes a little bit longer to get the good outcomes for these people. So if you have people who are complaining of visual triggers to vertigo, I'd recommend as well for them to go through a course of vestibular rehabilitation with also some mental health support. Then we have the general, these are going to be seen in the older adult population. that's going to present to us. These are going to be people that are not necessarily going to come to us with some elaborate vestibular diagnosis or some specific vestibular dysfunction or pathology, but they're going to just, there's two categories here. We have the people that have presbyostasis or presbyastasis. People say that either way, and that's just going to be the gradual decline of multiple sensory inputs with aging. So for example, those are your people that, you know, they're starting to not feel their feet as well, their vision's starting to change, and their vestibular system's starting to degenerate. So all their sensory systems are starting to get less and less afferent information for their brain, and those people respond well to vestibular rehabilitation, even in the absence of a specific diagnosable vestibular dysfunction, as well as people with disuse disequilibrium, which are those who are going to have a decline in their mobility but have negative testing when you assess their vestibular system. And then people also, I wanted to mention, we don't have it on this slide, but people also with central nervous system disorders like MS, Parkinson's, history of stroke, things like that, they also respond favorably to vestibular rehabilitation intervention, even in the absence of a diagnosable peripheral vestibular dysfunction. So I'll turn it over to Cynthia now for our fourth poll question.
Okay, Kim, we've got our fourth poll question, which is, do you often see older patients who are complaining of dizziness or vertigo and have not received a specific diagnosis? I'm going to go ahead and launch that poll. I think what we're addressing here is, as we discussed before, we hear a lot that especially older patients, but vestibular patients in general, take many years and see many different doctors before they actually get a diagnosis. And Vita recognizes that there are so many patients out there that are undiagnosed, and those are the patients we want to reach, because those are the patients I think we can help the most. I'm going to close the poll because it was unanimous. 100% said yes, they often see older patients complaining of dizziness who do not have a specific diagnosis. Obviously, we're right, and there is a great need here to increase awareness about how important it is to help patients get to a specialist who can accurately diagnose their vestibular disorder. Kim, back to you.
Yeah. Well, okay, great. So I think the key thing then, because I actually, in my practice, I practice in the state of California, and I practice primarily under the direct access law. So the majority of my patients now that come to me in my private practice, I don't even have a physician referral prior to seeing the patient. I just have to give the physician a courtesy notice that I'm seeing their patient, and then I have to send them requests and reports if I see the patient beyond a certain length of time. But the majority of my patients are coming to me without diagnosis, without referral, without any diagnostic testing. So I'm in the same boat as everybody else out there who's saying they're getting these people without diagnosis. And so my recommendation to you is, number one, you need to learn how to screen for BPPV and make sure the person doesn't have BPPV in any of their semicircular canals. And once that's taken care of, then you can certainly commence a program of vestibular rehabilitation based on their symptoms. If they're having motion sensitivity, or they're having balance problems, or they're having gait problems, or they're having complaints of gaze stabilization issues, you can certainly commence a vestibular rehabilitation program for someone to address those symptoms once we're sure they don't have BPPV or their BPPV has been cleared, even if you don't have a specific vestibular diagnosis, or if they don't have a vestibular diagnosis, but they do have vestibular type symptoms, like the people with disuse disequilibrium or people with central nervous system problems, because they do respond favorably to vestibular rehabilitation intervention. And I read a study a couple of years ago that said something like even 60% of people that just get a generic vestibular rehabilitation protocol still respond favorably. So it is better to tailor the specific vestibular rehabilitation exercises to the patient, but even if you just give them more generic vestibular rehabilitation interventions, a lot of times you still will get a favorable response, even if, as long as you've made sure the patient doesn't have any BPPV. So now what we're going to do is, and that, you know, it's a pursuit as far as a career. So some therapists I talk to working in geriatrics and physicians working in geriatrics that I work with, Some of them are interested in learning how to actually treat this and they want to be the person that is sought out for this kind of care, and that's what the continuing education courses, mentorship, and study groups that I offer support people in doing, is becoming that go-to person in their community. But then other people I talk to say, you know what, I'm not really interested in learning how to treat it. I just want to treat my geriatric patients, but I don't want to become a vestibular expert. And to those people I say, okay, well, at least learn how to screen for it. At least at the very minimum, learn how to screen for BPPV and learn how to screen for vestibular problems, and then know who you can refer to if you don't want to become an expert in how to treat it. So now we're going to have a look at, we're moving on now from the vestibular focus. We're going to look now at more the overall recommendations from the American Geriatric Society and the British Geriatric Society on fall prevention for older adults. And in the resources that we have for you, one of the resources Cynthia will be providing is a link directly to the American Geriatric Society. They have a summary of recommendations of what I'm going to present to you. They have a more lengthy document available for more details if you would like. But essentially what they're recommending, the American Geriatric Society, is recommending that all older adults be asked by a healthcare provider at least once a year if they've had a fall, and or if they're having any difficulties with walking and balance. So the overall message is that falls are not a normal part of aging and that most falls are preventable. So older adults who are reporting more than one fall or reporting difficulty with walking and balancing should have a fall risk screening performed by a healthcare provider. And one of the ones that we're advocating in the public health world, because I am the co-chair of the San Diego County Fall Prevention Task Force, so I do work a lot with the public health part of our country and our county here. One of the things we're using is the timed up and go test. So that's a fall risk screening measure that can be used by a healthcare provider. And then any older adult who either performs poorly on the fall risk screen, expresses a fear of falling, or has presented for medical attention for fall-related injuries should have a multifactorial fall risk assessment done. And that fall risk assessment usually is going to result in them being referred to some kind of physical therapy. Now that's the recommendation of the American Geriatric Society in terms of fall risk screening. And then the American Academy of Otolaryngology, which are the ENTs, the ear, nose, and throat doctors, in their BPPV clinical practice guidelines, as I mentioned, they are recommending that all older adults be screened for BPPV, especially those with chronic repeated falls. So in terms of overall geriatric fall prevention, and we do in San Diego, we've launched a class called the Ethics of Fall Prevention, where we're looking at the detailed recommendations for fall risk reduction, and can providers really implement them, and what the barriers are to implementing them in our clinical settings. So this webinar is just more of an overview of those evidence-based best practices for geriatric fall prevention, and those really, they fall into 3 categories, and we can never promise an older adult that they will never fall. We can never say to someone, you're never going to fall again. But what we can say is we're going to address the risk factors that increase your risk of falling, and the more risk factors we identify and address, it will actually have an exponential impact on reducing your fall risk, as opposed to a linear impact in addressing multiple risk factors. So there's 3 categories of fall risk reduction, which we're going to look at in this webinar: medical management, home and environmental safety, and then balance and mobility. Those are the 3 areas that need to be addressed in a comprehensive multifactorial fall risk assessment and intervention for an older adult. So in terms of medical management, this is where we really want to have the physicians involved in helping the patients to manage their chronic health conditions. In San Diego County, we have the Healthier Living programs. Other public health departments across the country may have education programs for chronic disease management for community members. That's really important for people to start using journals to track their blood sugar or their blood pressure. Things like self-assessment and monitoring, caregiver training, managing their chronic health conditions are really important for fall prevention for older adults. We want to encourage them to get their medications reviewed, and also remember that a lot of older adults use multiple pharmacies and mail order prescription services, as well as they get recommendations from their children on herbal supplements and vitamins and things that are over the counter that may interact with their prescriptions, and all of that may interact with alcohol. So we want to encourage them to get their medications reviewed by a pharmacist. There's also a website that I use called drugdigest.org where you can type in somebody's medication list and check for interactions through that website. That's a free service. In terms of medical management as well, the doctor is also going to be addressing with the patient in terms of their hydration, their nutrition, and if they have Meniere's or migraine variants, they may need to make some lifestyle changes that prevent or reduce the frequency of the episodes of vertigo that they're getting. So we want to encourage any older adult that's had an issue with falls, we want to encourage them to partner with their physician to manage their chronic health conditions and manage their medications and their diet and their hydration. So that's the last slide we looked at. The second pillar of fall prevention for older adults is going to be home and environmental safety. Now, as I already mentioned in this presentation, this is especially important for older adults with visual impairment. The home and environmental safety has not been shown to reduce fall risk as a standalone intervention, but it is encouraged to be part of a multifactorial fall risk reduction comprehensive approach, and it is especially important for older adults with visual impairment. So in terms of home and environmental safety, we have a home safety checklist on our website, sandiegofallprevention.org. But in general, we want to look at removing clutter from the walkways, and that's due to the changes to normal changes to vision, like problems with depth perception and contrast sensitivity, making it easier for people to trip. We want to increase the lighting, make sure people have night lights for their trips to the bathroom at night. Look at reducing glare, as we already talked about, installing light switches at the top and the bottom of stairs, grab bars, handrails for the bathroom, securing any loose carpeting or flooring. And then we want to look at changes to the bathroom, like a raised toilet seat, a handheld shower hose, grab bars, non-skid flooring, and things like that to prevent falls in the bathroom. So typically what the healthcare provider is going to do regarding home safety is just provide a home safety checklist to the patient unless they're a home health provider, and then they can go through and make specific recommendations for fall prevention. And then the third pillar for fall prevention for older adults, we looked at medical management, we looked at home and environmental safety, and the third pillar is balance and mobility. So in terms of all the research from around the world on fall prevention for older adults, the one thing that has been shown as a standalone intervention to reduce falls is exercise, reduces fall risk. So if older adults are only going to do one thing to reduce their fall risk, exercise is the recommended intervention. As far as the greatest protective effect from falls, that's going to occur with exercise dosages of 50 hours or more that includes challenging balance exercises. And exercises have been shown to reduce falls that are either individually prescribed, such as through physical therapy interventions, or as part of a group fitness class, as long as those exercises focused on strength, flexibility, balance, and endurance. So older adults should be referred to community exercise and balance classes as long as we feel they're safe for that. And anyone that we feel is unsafe to be referred to an exercise class or a balance class, especially those for seniors at community colleges and things, we should be thinking of getting them into skilled physical therapy for an evaluation and for an individually prescribed exercise program that takes into consideration their medical and surgical history. Also, I want to emphasize that before an older adult commences an exercise program, I personally recommend for them to be screened for BPPV, because if they have undiagnosed BPPV, then all the balance exercises in the world are really just going to aggravate their symptoms, and they're not going to get a long-lasting effect. So I highly, highly recommend for everyone to make sure they have ruled out or treated BPPV before they commence any other vestibular rehabilitation interventions or any other exercise programs. Now, as far as managing visual changes in preventing falls, as I already mentioned, the first eye cataract surgery has been shown to be intervention which can reduce fall risk. It is recommended for all older adults to get regular eye exams and manage their health conditions that affect their vision, such as blood pressure and diabetes, things like that. It is recommended for them to wear prescription lenses if they need to, and almost everyone over 40 needs some kind of reading glasses at the very least. It's recommended for all of us to protect our eyes from the sun because damage from the sun can damage our retina, the macula inside of our retina in our eye, which is essentially contributing to age-related macular degeneration. So it's recommended for everyone at every age to protect their eyes with sunglasses. And then one thing that's really important is to realize that older adults with multifocal lenses or bifocals have a higher risk of falling. It's been shown in research studies that those multifocal and bifocal lenses can increase the risk of falling because when people look down through the reading lens, they have a change to their depth perception, especially as they negotiate steps or curves. They're more likely to trip. So that changing their eyeglasses may reduce fall risk for some people. In fact, I had one lady recently who had had chronic dizziness for about 6 years since she got progressive lenses, and getting her glasses changed was really the only thing that relieved her symptoms. So we want to be aware of the risk that those type of lenses give our patients and just educate them that they may need 2 separate sets of glasses and keep their reading glasses in their pocket if they're having falls on curbs or steps. There is also a specialty, a low vision specialty, which some occupational therapists pursue. I think there may be some physical therapists that pursue low vision as well. And so that would be something that you can refer people to if they're having actual visual disease or pathology or need more specific training on how to manage their life with visual changes. Now, in terms of managing the somatosensory changes, again, similar with vision, we want to look at managing the underlying conditions that are contributing to this. So that would be managing blood sugar, managing diabetes, and then we can be educating our patients on proper foot care if we do find that they have neuropathy of some sort so that they don't end up with infections and things like that. And then it's recommended for people to exercise, to stay active, to continue to get the blood circulation in their feet. We'll have more information probably on somatosensory changes in a future webinar. We won't cover too much about that today. As far as the cognitive impacts of falls in the older adults, one of the things that we want to be aware of is that sometimes there's confusion between people that have dementia, people that have delirium due to an acute medical issue, and people that have an undiagnosed BPPV, because all of those presentations can present with an initial low-level confusion and some issues with concentration and memory loss. So we really want to be digging deeper into differential diagnosis for any of our older adults that are presenting with confusion, brain fog, lack of attention and ability to focus, and then just understanding the role that cognition plays as far as, you know, people that are overly confident and they don't respect the limits of their balance. They need some education about their fall risk. Then we have people that are in denial. I'm sorry, those are the same people. The people that are not respecting the limits of their balance are the ones that are in denial about their balance issues. And then we have people that are afraid and they have excessive fear. And then we have people that just have limited safety awareness because they do truly have a new onset of mild cognitive impairment or dementia. So that's an important thing to work with a physician on differential diagnosis of. And the other important point that I want to make here is the last bullet on this slide, which is that the vestibular suppressant medication, that meclizine, it does have a long-term, well, short-term, it can cause drowsiness and blurry vision, which can contribute to more falls in older adults. But long-term, if we have all these older adults with undiagnosed and untreated vestibular problems who are just being medicated with the meclizine to reduce their symptoms, they're still going to be having balance problems and gait problems because the BPPV hasn't been treated and assessed. But they're also potentially going to develop long-term irreversible cognitive side effects from the use of that vestibular suppressant medication. And those are called anticholinergic effects, and they are cumulative over time. And the meclizine, which is given for vestibular suppressant, is in the top tier of medications that are shown to have cognitive side effects with long-term use. So my point in advocating for this population and bringing this urgent message to you is that we need to look at how we can get our older adults off the if it's appropriate, assess their BPPV and their vestibular problems, give them a targeted intervention and treatment plan to reduce, if not completely eliminate their symptoms, and then they won't need these vestibular suppressants long term, and they can avoid the potential cognitive side effect of long-term use of vestibular suppressants. Now, there are some people that need long-term use of vestibular suppressants, and those are people who have a poor prognosis for a full vestibular recovery, or who have central nervous system issues that are going to prevent a full recovery. And in that case, the goal of the long-term use is to just improve their quality of life. So there are emotional impacts of having falls in the elderly, as far as, and also having chronic problems with vertigo and dizziness. We touched on this a little bit already, but fear of falling is the most common fear in the elderly. It can lead to anxiety, panic attacks, depression, agoraphobia, suicidal ideation. And so sometimes our patients with vertigo or chronic unexplained falls and dizziness and imbalance, they do need professional mental health support. We want to be aware of that so they can have a full recovery. What percentage and proportion of patients who have fallen are reporting that they have experienced anxiety and or depression? Just curious. Cynthia's going to host this poll for us.
Yeah, so I went ahead and launched the poll, and I just wanted to share with you all while you're answering that. My mother has Meniere's disease. She's in her early 80s. She's had it for over 30 years, and I can attest to how it has impacted both her, her cognitive abilities, but also her her emotional state. She definitely suffers from anxiety because she has fallen many times. She never knows when she's going to fall, and she suffers from depression as well because of a loss of her independence. She knows she relies on others, on her family and on friends in some cases, and she knows what a burden it is for them. So I can't overemphasize how important it is to address the emotional aspects of vestibular disorders with all patients, and especially with older patients who may be resistant to different types of mental health therapy because they don't want it to they don't want to admit that something's wrong with them or have it appear that they are crazy. So I think referral to appropriate mental health specialists and just compassion, really, and also helping the family members of these patients understand what's going on for them so that they also can have compassion, can make a big difference in a patient's life. I'm going to go ahead and close this poll. It looks like we've got 19% said that less than 25% of their patients that have fallen experience anxiety and or depression. 23% said less than 50%, and 58% of you said that more than 50% of your patients who have fallen have experienced anxiety and or depression. So I think it really is very common, and maybe even more common than we imagine, because I think a lot of people, they cover it up, they don't show it, they don't want to admit to it. So
yeah, exactly. And I think, if we're going to give someone a full recovery from a vestibular problem, we need to address that hyperactive state of their nervous system that comes in response to these symptoms. So absolutely, I love that, addressing and realizing where the scope of your practice ends and the scope of someone else's practice begins. A lot of times for a full recovery, it takes a team of professionals. But the key is to get that differential diagnosis up front so we know what we're dealing with and we can give people a reasonable prognosis and expected outcome from what we're suggesting. So now we're going to have, I think we have about 6 slides left, and these are going to cover the general recommendations for management for these patients. I think we've already covered a lot of the recommendations, but the key thing is to make sure to ask everyone over 65 at least once a year if they've had a fall. That's from the American Geriatric Society, and then to be screening everyone over 65 for BPPV because of its prevalence in that age group and its contribution to falls, and now its increase in the risk of fracture when we fall. So in terms of addressing vestibular causes, we want to make sure we get down to the cause of the symptoms of dizziness, vertigo, or imbalance. And then if you are not a vestibular specialist or someone who aspires to be a vestibular specialist, go ahead and refer your patients to a vestibular specialist if you've screened them as having a vestibular problem. So we want to be alert for the possibility that people need to be referred to diagnostic testing as appropriate, and then engaging, as we discussed, an entire team of healthcare providers as needed to further investigate any additional complaints that we can't address within our own scope of practice. So in terms of the prognosis for vestibular recovery, BPPV can be fixed in one treatment session about 85 to 90% of the time. I'll tell you, the first lady I treated had had it for about 20 years. We fixed it in 2 sessions, and it was probably the best day of my whole career until the next one that I fixed, and it just keeps going like that. So it's a beautiful thing to offer people relief if we can develop those skills. And then in terms of vestibular decompensation or chronic vestibulopathy, we're looking at that usually typically improving significantly within 6 to 8 weeks of vestibular rehab. And there have been studies that show people over 65 do respond favorably to vestibular rehab intervention. So there's no reason an older adult would not have should not in general be expected to have a good outcome. You know, of course, comorbidities and other neurological conditions would factor into the long-term prognosis. But we want to be educating people about self-care and management if they have a prognosis for a long-term vestibular problem. And if they do have a vestibular hypofunction, we want to make sure they know that a lifetime of exercise and head motion is required to maintain the recovery they get from our vestibular rehab program. In terms of other strategies for recovery and healing, we'll look now at what other providers might need to be involved in an overall comprehensive treatment plan. So the primary care doctors, the geriatric doctors, are going to need to be involved to manage the medications, the chronic health conditions, the nutrition, and the hydration, as we discussed, and then also refer on to any other specialists or get involved in any diagnostic testing that they feel needs to be addressed. We want patients to be inquiring about exercise and asking for referrals to physical therapy if they are not sure what exercise is appropriate for them. In terms of other healthcare providers we might want to involve, typically we want to look at involving a physical therapist who specializes in vestibular rehabilitation. That would be for the balance gait component, and they can also address symptoms of vertigo, dizziness, and gaze stabilization, or the visual field moving with head motion. The patients may need to be referred to an occupational therapist if they're having difficulty with their activities of daily living, or if they want a specialty low vision consultation. And then, as we mentioned, professional mental health services may need to be involved to address the anxiety and the depression that may come along with having a vestibular problem. And then we may need to give people an assistive device if we feel that they're going to continue to have problems with their balance and continue to be a fall risk. Also, we want to encourage our patients to just enjoy their life. You know, sometimes people can get so stuck on, you know, what is my diagnosis and all these kind of things. They want some answers so badly that they completely miss out on the present moment of their life. So we want to just, you know, sit with them, and as Cynthia said, you know, have compassion when they're telling you about their symptoms. Sit and listen and say, I'm so sorry you're suffering, and I'm here for you. You know, tell your friends and family how you're feeling. Ask for support. Can you watch a funny movie? Can your grandson pull up the funny clips from YouTube for today for you to look at and try to improve their mood and their quality of life, regardless of their prognosis, so they just enjoy their life more? And can we encourage them to laugh, because that's going to shift their nervous system, and engage in creativity like art or music or things they enjoy in their life. We can also just encourage our patients to just sit and breathe and smile. Sometimes just breathing and smiling can change someone's mood. To picture themselves healthy and happy. In fact, I encourage my patients to use affirmations to imagine themselves living a life in perfect balance, for example. And then if someone needs ongoing support because they have a poor prognosis for a complete vestibular recovery, I know, Cynthia, that the Vestibular Disorders Association has online support groups, And then a lot of local communities also have live and in-person support groups for long-term emotional support. So that is the conclusion of our webinar for today. I want to thank everyone for their attention, and thank the Vestibular Disorders for an opportunity to share this information. I would love to stay in touch with everyone who wants to stay in touch with me. I do have a YouTube channel called Kimberly Bell, and it's spelled Kimberly with an L-E-Y, where I have some frequently asked questions that I hear from patients. And I have some music and some drumming and some other things I believe are important for a complete vestibular well-being. And then I have a website, betterbalanceinlife.com, that has a mailing list where I email out newsletters and interesting information about these topics, as well as my upcoming continuing education events. So thank you so much for this opportunity, Cynthia.
Thank you, Kim. Thank you so much for taking the time to share your expertise with us today on balance and aging in older adults. I just want to remind people we're kind of out of time for the most part, but I do want, if you have a question, feel free to type it into the questions area, and we can try to address some of the major questions, and/or what I can do is take down some of the questions and we can answer them and via an email that we can send out to you later on. This recording will be available later on, and we'll be sending out another email to all VITA professional members later on with a link to this recording. And if you have a question that you did not get to ask today, please feel free to email me. I'll give you the email address that's really easy to remember, or you can use the one that's on the screen here. There's info@vestibular.org, or you can email me directly at VEDA, V-E-D-A, @vestibular.org. So I think we'll go ahead and close up today. Thank you everybody for attending, and just one more reminder, we are in about a month we're going to have a presentation very similar to this that is geared toward vestibular patients. It will be slightly more abbreviated than this presentation. Won't go into as much detail on the clinical end, but it'll be geared toward vestibular patients. We'll be sending that information out to people that are on our mailing list. So if you have patients that you would like to refer to this, please encourage them to go and sign up for our mailing list on our website and become a VITA member. This will be, the webinar will be specifically as a benefit to VITA members, so they can become a VITA member on our website, and if they have questions, contact us at the information on the screen here. Thanks everybody again, and have a good night.